Day? It's
Fine.
morning in France, right?
What about you?
Yes. And now in Vietnam now is 1:30 p.m. In France, maybe in the morning, right?
Yeah, it's early in the morning. Yeah.
Yeah. Xin kính thưa quý vị đại biểu, thì chúng ta sẽ tiếp tục cái phiên khoa học buổi chiều đầu tiên hôm nay. Thì cái phiên này là sự kết hợp giữa Hội Điện quang can thiệp Việt Nam với lại Hội Điện quang can thiệp trẻ thế giới IUOIA. Thì thông qua Hội Điện quang can thiệp trẻ thế giới đã giúp mời khá là nhiều các giảng viên speaker từ Mỹ, châu Âu để giúp cho chúng ta là tổ chức thành công cái hội nghị điện quang can thiệp năm nay. Thì cùng với chủ tọa đoàn với tôi trong cái phiên này thì có tiến sĩ Võ Tấn Đức và giáo sư Prof và giáo sư Vidal. Thì hiện tại thì giáo sư Prof và giáo sư Vidal sẽ có mặt online cùng với chúng ta. Thì riêng bác sĩ Ahmed Nina thì đây là hiện nay đang chịu trọng trách chính của cái Hội Điện quang can thiệp trẻ thế giới, thì có gửi cái bài giới thiệu và cũng không có mặt được do cái lịch công tác. Thì, and good afternoon from Vietnam and morning in France to Dr. Professor Lopoy and Professor Vidal. And thank you very much for joining with us for organize this congress. And I hope that in the future, and IUOIA continue to help us in the future to organize congress also for training and to help us in the intervention procedure in the future. And now we have a section in the first. Can you introduce from Professor Lopoy and Professor Vidal, please?
So hi everybody, thank you very much for invitation. It's a great pleasure to be part of this with all of you guys. And so this is my pleasure to introduce Dr. Ahmed Neglila for this introduction of this session between the Vietnamese Society of Interventional Radiology and the International Union of Interventional Radiology. So thank you very much.
Yes, thank you very much, Professor Lopoy. Please, Professor Vidal.
Hello to all the Japanese, Vietnamese societies of radiology. I'm very happy to share this discussion with you And thanks again for the invitation.
And thank you very much. And first, I'd like to introduce Dr. Ahmed Belila first. Introduce about the IUOIR. Please, the record presentation.
Hi, ladies and gentlemen. I'm Dr. Nijila from France. I'm from the International Union of Interventional Radiologists. I'd like to present this society. First of all, I would like to thank the Society, Vietnamese Society of Interventional Radiologists for this invitation. The International Union of Interventional Radiologists is a non-profit society where the idea born in 2008 at the RSNA Congress, where many radiologists from all over the world met at this Congress and decided to build this global organization with a mission of transferring expertise and sharing best practice in this subspecialty. So the main aim of this association is to transfer experience and to exchange with the hospitals and departments in many countries in the world. We performed many procedures as vertebroplasty, gastrostomy, and embolization, and many other procedures. The activities we work in four type of activities as training in situ. We expert moving to the countries to exchange and to do some conference as we did in Vietnam and Egypt and other countries. Then we offering some intervention radiology observership and diagnostic also, which was in France and Germany and USA, many departments. Then we are participating in many congress. We had a post in RSNA, in CERSI, and VSIR in France. Otherwise, next step, we hope to offering and send materials to countries in the future. So we have some observership in Germany, Professor Vogel, and in USA, Professor Jarvik, and in France, Professor Coutin and Professor Provo. Next step, we have some news in 2022. We would like to invite you to visit our booth at RSNA, and we expect to open our office in USA this year. And we received 2 positions for observership in Germany and France. So we hope many radiologists to, we encourage everybody to join the Doctors Without Borders, trained to help people in their own country and even beyond their country borders. So thank you very much for this short presentation. Thank you.
Thank you for your presentation of Professor Neglia.
And next speaker, I would like to introduce Professor Vidal from the University Marseille, Aix-en-Provence. Xin giới thiệu với lại các anh chị và các bạn. Tiếp theo chương trình thì chúng ta sẽ nghe cái phần trình bày về một chuyên gia chuyên về thuyên tắc mạch. Ông đưa ra hai cái quan điểm lớn, đó là cái tắc mạch trong điều trị trĩ, cũng như là một số cái vật liệu về tắc mạch rộng rãi có thể ứng dụng được ở các nước đang phát triển. Thì chúng tôi xin giới thiệu hai cái bài trình bày tiếp theo là của Professor Vidal. Ông là một chuyên gia về lĩnh vực điện quang can thiệp của Đại học vùng Aix-en-Provence, Marseille 2. Thì tiếp theo là cái phần trình bày của ông. Je vous présente Professeur Vidal. Présente votre présentation, s'il vous plaît.
Merci beaucoup. Thanks a lot.
Hello.
My presentation is ready. I'm very happy to share with you this conference about Emborrhoid therapy, and thank you again for the invitations to your Congress. So, as you can see, this is the anatomophysiopathology of Emborrhoids, and it looks really complex. There is plenty of things, but which is interesting to us, it's the blood stagnations with hyperarterial or of the sinusoid, which lead to spurting, hosing, and finally, which will be the main symptoms which is interesting to us. Of course, there are also pain, and we'll see that incontinence, itching, soiling are more related to aging and to the prolapse. So 15 years ago, around, people asked for these tools, which is Doppler guide hemorrhoid artery ligation, and the surgeons go inside the rectum and do a ligation of the suprarectal artery. That means that we propose to do the same thing, but not using internal suture, but doing the same thing with inserting a coil here at the same place, but via an endovascular way. If you look at what is internal hemorrhoids, it is clearly a physiological network. The role of this complex is to participate to the resting anal pressure. So this is 20% of the closing rectal wall, and when it begins to increase in size, it's bleed, and finally it can go out of the rectum. So there are three cushions, and these cushions are mainly vascularized by the inferior mesenteric artery. You see here on this posterior view of the rectum, this is the superior rectal artery, which are interconnected with middle rectal and inferior rectal artery, and the main vascularizations come from the superior rectal artery. So you can see that the anatomy of the superior rectal artery are almost always the same model. There is two main branch, one right, one left, and the posterior trunk, which give a smaller branch. You can see this artery and the entering in the hemorrhoidal cushion on CT. Here you have a CT reconstruction, and you can see here very well how this works. You can see also the artery, but the drainage vein on the CT. It depends on the time you come. You see here the superior rectal artery and the drainage vein, which is there. So here you have the internal hemorrhoids, which can go down and give clearly a prolapse on the. And here you have the Gallagher classifications, which give fourth stage. The first stage there is no illness. On the stage 2, you have hemorrhoids, which are congestive but without prolapse. On the stage 3, you have a prolapse which is reducting. You can reduce the prolapse. And the stage 4, the prolapse is so important that you cannot reduce it. We have to notice that rectal bleeding are, of course, related to cancer, but in 5 to 50% of the anemia caused by lower GI bleeding originate from hemorrhoids. That means that people coming to the consultations come often with anemia. Some of them had transfusion, blood transfusions. It's very interesting because the corpus cavernosum recti that you see here, which creates the anal cushions, it has been described in 1964, and you have the artery which comes directly in the venous lake. There is no interposition of tissue between the artery and the vein, and that's why it creates this cushion. You see this small artery coming in the corpus cavernosum recti. You can see it very well in angio. And the role of that is not to bring oxygen to the rectum because there's no tissue. It's really to create an arteriovenous shunt. And this shunt will create the cushion. That's why you have red bleeding when people come to the consultation. They said, clearly it looks like arterial bleeding and not like venous bleeding. Interestingly, here you have the illness of the hemorrhoids pathology. So here are people with stage 3 and stage 4 with big hemorrhoids. When you look at Doppler of the superior rectal artery, in these populations, the arterial flow and the caliper, the size of the artery, are bigger than in patients who have no hemorrhoids. That means that if you have big artery, you will develop hemorrhoids. And if you look at the Doppler of this artery, you see that there is a very low resistance index. That means that there is no interposition of tissue, and it's really an arteriovenous shunt. If you look at the arteriograms, here the catheter, it has the distal part of the inferior mesenteric artery. When you inject, it's 2 images per second. You see this is the left superior rectal artery here, and the left superior rectal artery entering here the corpus cavernosum recti. At the time when it comes here, you have here the drainage vein, and there is no interposition of tissue. You see no parenchyma here. It is clearly a drainage vein, and this is the physiological network that we call corpus cavernosum recti, which create the hemorrhoids. So in 2007, we were asking for the first patients, and if we look to the literature, you can see that there are some previous embolization which has been done, but only in emergency for people who bleed with life-threatening emergency. So if there was no ischemic complications in these patients, why will it lead to complications for chronic bleeding? So we have done one of our first case in emergency. It was a young patient, which has had a resuscitation at ICU because he had a massive bleeding 10 days after a surgery. You see here the bleeding. He had a surgery of hemorrhoids, and the wounds bleed. So we go in the inferior mesenteric artery. Here is the left superior rectal artery, and you see here that there is a bleeding in the rectal. So it's for interventional radiology, it's really simple to come here to insert, you see the microcatheter, to insert a small coil, and it does the job perfectly. The surgeons understand very well at this time that if you can do in an emergency way, you can do it for a chronic way. So we use this type of microcoil, which are 2 or 3 millimeters, which are fibred, and we use a Siemens or a sidewinder catheter to go inside the inferior mesenteric artery. So here is the setup in Marseille. So you can see, for example, a 3D CT of the inferior mesenteric artery. You don't need to do a 3D CT all the time, but it can be helpful because you have all the images here, you see, of the superior rectal artery. And when you have the 3D reconstructions, you see very well all the branches coming. You can also have an axial view, and you see the artery entering in the corpus cavernosum recti. So you can have these images really nice on your screen. So I try to come with the microcatheter as far as possible, as close as possible of the pubic bone. And you see the distal tip of the microcatheter, which is here. This is the terminal part of the suprarectal artery, and with a connection with inferior rectal artery and pudendal artery. And I'm going to insert coil here. You see, I insert small coil of 2 millimeter. And it's nice because it leads to a very quick occlusion. And there is some other branch. So usually you have 2 to 3 branch to embolize here on each side. You see, you can come very deeply with the microcatheter. When you have done the branches of one side, you can go on the other side. Here you see on the right, the microcatheter, which is coming here very close to the pubic bone. You see here, it's very small artery. This is a very small extravasation. Here is a small artery again, which is communications with middle rectal artery. And we are going to inject on each branch some microcoil. I try to go as far as possible. Here you see the final control. Our goal is to have no more artery coming below the pubic bone. And in the final control, you see that here you have still something. So you need to go and check the posterior trunk. This artery, you see, is not blocked. And this artery take in charge this branch, which goes again in the anal canal. And you need to do that to obtain a complete control. And the complete control is there. I have no more artery. So if you look on what this is the insertion of the micro coil, you just have to push, and you can flush it with liquids. In fact, it's a good technique because it goes quick. You see here the distal tip of the microcatheter and the coil is coming. So it's interesting because it goes quick and do a very nice job. See here again, first will be more magnified. Here you see insertion of the coil which comes. Okay, so the first paper has been published in 2014 with the first 14 cases. Sometimes when you do the inferior mesenteric artery angiogram, you see no artery coming in the rectum. Does that mean that there is no artery? Of course not. That means that it comes from other artery. So here you have to go as far as possible with your microcatheter. And when you inject, here you have nothing. But if you come with your microcatheter in this branch and you inject, you will depict this big artery, which is a middle rectal artery. And the middle rectal artery take in charge the main part of the superior rectal artery. Well, look at that. When the microcatheter is going back in the middle rectal artery, you find all the artery that you don't see from the superior rectal artery. Here is the same. You have here an example of injection, no artery, but how to depict this artery is to go as far as possible. You see here, we have embolized 2 branches on the left, 2 branches on the right from the superior rectal artery. And now we are coming, this is the pudendal artery, this is the middle rectal artery. You see the size of this artery, which takes part of the corpus cavernosum recti. So here is another example. You have left superior rectal artery, right superior rectal artery, posterior trunk. When you go down, you inject, you see up this. This is the middle rectal artery. And you see the size of the middle rectal artery, which is almost the same size. Here's the middle rectal artery. You inject. This is not a vein. This is clearly the middle rectal artery, which is as big as the superior rectal artery. So now we come from the middle rectal artery. And when you inject, you have a backflow here, which comes and try to revascularize the superior rectal artery, which we have embolized. So that means that we have done first embolization of the superior rectal artery. We have found the communications with the middle rectal artery. So you need to embolize this middle rectal artery. If you don't embolize this middle rectal artery, you will not have done all the job. It's really important. So we have two types of patients. One type of patients where you have superior rectal artery right and left, and no middle rectal artery or very small middle rectal artery. And of course, there is always an inferior rectal artery. So in this case, you have to embolize only superior rectal artery. And around 30% of the patients have superior rectal artery with big dominant middle rectal artery, which can be unilateral or bilateral. In this case, you have to do embolizations of both, of course. So this is the type 1. You have no middle rectal artery depicted, so do embolization of the single superior rectal artery. And this is type 2. You have here left superior rectal artery with a huge connection with this middle rectal artery. The size of this middle rectal artery is bigger than the superior rectal artery. So clearly you have to embolize here on the left, and on the right is the same, you see. So how to do the embolization of the middle rectal artery? The best, if you have the tools, is to do the CT, the angio-CT. With the angio-CT, you have a 3D roadmap, and with the 3D roadmap, you can do easily catheterizations of the middle rectal artery, which can be embolized. Of course, when we do embolizations with coils, you can imagine that you don't reach the corpus cavernosum recti. If we had the opportunity to insert sphere inside, it can lead to a better result, but it can lead also to ischemia. So at this time, we think that it is still better to use particles. I don't have time to develop all the results, but for the beginning of the procedures, I think doing only coils is clearly the best. The point which is very important is that patients come for functional symptoms. So you need to speak with them at the consultation and say what is the definition of the clinical success. And the clinical success, which has been defined in this Lancet study about ligations of hemorrhoid versus Doppler ligation, is at 1 year, do you feel your symptoms from hemorrhoids are cured or improved? This is a clinical success. Or if it's unchanged or worse, this is a failure. And it's really important to say to the patients, okay, we are, see, how do you feel? And there is plenty of score, hemorrhoid severity score, incontinence inventory, pain, but they are not relevant of what the patients feel. And finally, which is the most important, is what the patients feel. So we have created also a bleeding score because there was no bleeding score. This bleeding score is important for us because we are treating most of the patients which come with rectorrhagia. They come because they have hemorrhoid stage 2, stage 3 with bleeding. So it's important to have a score. So if we look at all the theory which has been done, we can say that the technical success is good, is around 100%. It's not a big challenge to do with embolizations. The clinical success leads to 70 to 85%. It depends on what is the definition of the clinical success. It depends on plenty of things. If we look at all this theory, no major complications has been described, but they are not really comparable because they are not looking for the same thing, the different score. Anyway, now we have some clinical study which are a really nice way. And now we have a study about transradial access, I think, which is great technique because the patients can go home and work really easily. And there is also some meta-analysis which give clearly the clinical evidence of this treatment. I don't have time to go deeply in this meta-analysis, but so finally, what can we say about Emborrhoid? We can tell that does it work? Yes, the embolizations of the superior rectal artery and middle rectal artery works for bleeding. That means that when the patients come and said, my trouble with hemorrhoid is bleeding, in 80 to 85% of the case, you will have big ameliorations on bleeding and the patients will be happy. When the patients come because he has pain, it's complicated, and be sure that the pain is related to hemorrhoids. If the patients come and say, I have pain so intense that I cannot sleep, for example, Usually it's not hemorrhoid. It can be fissure, it can be hypertony of the sphincter, it can be a lot of things. So works with proctologists, with surgeons to be sure that the pain is related to hemorrhoids. When a patient comes because the main symptom is prolapse, if you reduce the blood flow, you will reduce the size of the hemorrhoids. But if there is a stage 3, stage 4 prolapse, which is the main symptoms, the patients will have perhaps not enough ameliorations to be happy. So the main patients which need to be treated by Emborrhoid is the patient which bleeds clearly. The level of evidence, of course, we need still a randomized trial. There is a randomized trial which has been done in Brazil, but which is still not published, has been presented in a congress. You have to remember that hemorrhoid recurrence at 1 year with Emborrhoid, it's around 25%. And with Doppler ligations, it's 30%. And with rubber ligations, it's 49%. That means that we have very good results with a technique which is minimally invasive because there is no wounds in the rectum. So the main thing is to have a good selection, bleeding. You need to treat the middle rectal artery also when it's a stage 2. I think doing embolization with coil is the best because it's completely safe. And for follow-up, you have to look at the patient and say, is he happy or not? Thank you for your attention.
Thank you very much for very excellent presentation from Prof. Vidal. And the question will be at the end of the session. And we continue with the next speaker. I'd like to introduce Professor Lefroy. He's vascular interventional radiologist in Department Vascular Interventional Radiology in François Mitterrand University of Dijon, France. He is specialist in embolization of peripheral vascular and gastrointestinal bleeding, and also in IVF. So I'd like to introduce the topic from Professor Lefroy, practice creation of IVF for hemodialysis. Please.
Good morning, everyone. Thank you very much for invitation. It's a great pleasure to be part of this. So in this session, I will have two talks, and the first one is about percutaneous creation of arteriovenous fistula for hemodialysis. So let me show you our experience about that. So first of all, let me remind you some very simple things about arteriovenous fistula for hemodialysis access. You know better than me that the goal is to obtain a superficial vein with sufficient flow in order to allow dialysis. Usually we use surgery for this to connect a vein to a closed artery in the forearm or arm usually, and part of the arterial flow will be diverted into the arterialized vein. Of course, with pressure increase and dilation, the goal is to get sufficient blood flow and to facilitate puncture. And we need the flow of at least 600 milliliters per minute with a vein diameter at least 6 millimeter and maximal depth 6 millimeter. Otherwise, it can be difficult to puncture, and we need ultrasound. So usually, as I said before, this is performed by surgery under local regional anesthesia as an ambulatory procedure, or in a patient who is hospitalized, and we need at least 6 to 8 weeks to get maturation for before dialysis, of course. And sometimes we need a second intervention if the vein is too deep, which is called superficialization of the vein in a second step. So some rules and principles with fistulas is that we have as much as possible to use a distal radiocephalic arteriovenous fistula. It should be the first choice because in terms of patency, we know that this is the best option for long-term patency, but this is impossible or at risk of lack of maturation in up to 30% of patients for many reasons. For vascular condition, for calcifications, because of diabetic patients, polyvascular patients, making potential anastomosis between the artery and the vein quite difficult and at risk. So the second choice would be in that case humerobasilic or humerocephalic brachial arteriovenous fistula, usually in 2 steps, but we know that the long-term patency is lower, with some potential complications like Steele syndrome, aneurysm, making this option as a second option. So is there a role for radiocephalic proximal arteriovenous fistula, which is between both? Yes, with the creation of percutaneous fistula under ultrasound, I will show you. So the goal of our study was, of course, to assess the feasibility, safety, and efficacy of percutaneous arteriovenous fistula creation for hemodialysis access with the thermal resistance anastomosis ellipsis device, which is a specific device, as you can see here, with a small generator, as you can see on the left side, and a needle that we connect to the generator. This is usually made under ultrasound. We don't need any X-rays. With very simple things, a 5 French small sheath, and then everything is made in the lab, but under ultrasound, as you can see here. And we need to know by heart the anatomy in the band of the elbow, which is a very specific anatomy, and you know that we have the perforating vein, as you can see here, which is connecting the superficial and the deep venous system. The basilic is giving the medial basilic vein, the cephalic, the median cephalic vein, and from that point, the perforating vein makes communication between the superficial and the deep venous system, and the proximal radial artery is just close to this perforating vein, and this is the target to reach in that case by endovascular approach. I will show you. So we usually make this kind of procedure under local anesthesia, or mainly now with axillary block. This is preferable for 2 things, because we get vasoplegia, and the veins and the arteries are bigger in that case, which makes the procedure easier. So the goal is to puncture the cephalic vein, as you can see on the sagittal view, by ultrasound with a 20 gauge needle at the elbow, a crease under ultrasound guidance, as you can see here, and this is the perforating vein and then the proximal radial artery, and we have to navigate with the metallic needle into the median cephalic vein and perforating vein, and at that level to puncture, as you can see on this picture, the tip of the needle to puncture from that point the proximal radial artery, which is very easy under ultrasound, especially after vasoplegia, and you can see here from the vein to the artery. Then in that case, we have to insert a small guide wire, or 40-inch guide wire, and then on this guide wire we can put 6 French sheath from the venous side to the arterial side, and we put the sheath in the artery to make the first hole, I would say, which is very important for the rest of the procedure. And then we insert into the sheath the needle with 2 components, 2 thermal components deployed under ultrasound guidance. You can see on this picture the 2 components which are very easy to see under ultrasound. One deployed in the artery and one in the vein, and you can see the window between both, and then we have to bring closer the window. Normally this is 7 millimeter, and we need not 0 but at least 1 or 2 millimeter to be able to close it and to close this window and to bring closer the wall of the vein and the artery. And then we can apply thermal energy, which is a cycle of several seconds, let's say 15-20 seconds, very short, to make the anastomosis between artery and vein by thermofusion. And then the arteriovenous fistula is created, and you have to jump to withdraw the device. Let me show you this very quickly with a video, a specific video. So the device Ellipsis was initially made by a startup, Avenue Medical. It has been bought now by Medtronic. So we have to puncture under ultrasound the vein and then pass through the medial cephalic vein, the perforating, and to puncture the proximal radial artery, and then you insert the sheath on that, which is something easy. So you can do it by axial approach or sagittal approach under ultrasound. It's up to you. You can do both, and then on the guide wire we insert the needle. You can see the window that you have to insert closed, and then you open it after that, and then you remove a little bit the sheath, even completely, and then the two components are one in the artery and one in the vein, and you bring them closer to close the window, and then to be able on the generator to apply thermal energy and get creation of the arteriovenous fistula. So this is very easy to do, I would say. This is the first step. Now, in addition to this procedure during the same intervention, we systematically do balloon dilation with a 5 millimeter in diameter balloon to accelerate maturation of the fistula and to get earlier use. As you can see here, you can do it under ultrasound. We see the balloon very well here to dilate the anastomosis immediately. There is no risk of hematoma or complication. You can do it without any X-ray. It has been modified, this technique, by my friend Alexandros Mayos, who is the pioneer for this technique. And this is the final control, and you can see under ultrasound the connection between the vein and the artery and the fistula that you can see here. So this is the technique, and so we performed, we analyzed our experience with 25 patients over the last 3 years under local general anesthesia with this device. So as you can see here, many Caucasian patients. Of course, most of them had no catheter dialysis before and no previous arteriovenous fistula before. So it was a first one in the majority of patients, mainly on the left. We did the first 3 patients under local anesthesia, but honestly, this is really better under regional block and regional anesthesia to get vasoplegia, no contrast, no X-rays, and angioplasty of the anastomosis all the time now during the intervention to avoid postponed dilation of the anastomosis, because stenosis, of course, is the main potential complication. So for all patients, as you can see here, you can see the blood flow at follow-up, ranging from very small and immature in 2 patients up to more than 1 liter per minute, which is very interesting, and with no reintervention in most of cases. And every time we got reintervention, it was mainly anastomosis PTA. So 100% in terms of technical success. Cumulative patency at mean follow-up 96%, very high. Average blood flow at mean follow-up more than 800 milliliter per minute, as you can see, which is quite interesting after almost 20 months of follow-up. Reintervention during follow-up in 6 patients, mainly PTA of the anastomosis, and in 1 patient basilic vein embolization. Sometimes we can have to embolize some collaterals to redirect the flow. No readmission, no complications at all, thrombosis, hematoma, nothing about that. Just anastomosis, stenosis, and the mean cannulation time, as you can see, 6 weeks. And the type of cannulation, normal or Y, with no mortality, of course. So you can see on this picture the kind of cannulation we can get, a normal one or a Y one on both veins. And when we have to do angiography for this kind of patient, it can be very challenging because the anatomy is very special here by radial approach during follow-up, and you can see the stenotic lesion at the anastomotic level here. And we decided to, in that case, to put a plug in the in the basilic vein, as you can see, to get a huge and big cephalic one, and then to do angioplasty and stenting of the anastomosis. And this is the final result. And this is one of the first patients we did with, who is still patent with a good flow in the fistula. And you see the specific anastomosis you have between the proximal radial artery and the cephalic vein in that case. So of course, some papers now in the literature about this technique as compared to surgery. We have no scare. This is still a radiocephalic fistula, not humerobasilic fistula, so which is supposed to be better in terms of long-term patency. With immediate adequate blood flow after anastomosis dilation. No incision care again. This is a low flow and low pressure fistula, which is very interesting to avoid long-term complications of normal fistula with potentially a lower rate of complications. So if we look at the literature and the first pivotal multicenter trial in the US, about among 261 patients, only half of them, even less than half of them, were finally treated, meaning that there is a selection that you have to make by ultrasound. You have to do it by yourself to make sure that the patient is a good candidate for that. But in our experience, of course, we did less patients, but this is almost 90% of patients. You can try the left or the right, but you have to select the patients to make sure that the anatomy is favorable for this. And you can see the flow in the fistula from the procedure to 1 year up to 1 liter per minute. And the main complications at the initially in the first papers was, of course, the need for embolization of some collaterals and angioplasty of the anastomosis. As you can see here, up to 22% of patients. That's why now we do it directly during the first session and the first intervention. And this is the kind of cumulative and functional patency you can get, which are very high, of course. And if you look at the biggest series from Alexandros Mayos, it has been published last year, about 205 patients, 99% of technical success after mean follow-up of 11 months. You can see the primary patency, primary assisted patency, and secondary patency rates, 65, 88, and 97, with no serious adverse events, a mean access flow of 874 milliliter per minute, no Steele syndrome on the long term, very important and very interesting. Only 7% of patients needed a secondary superficialization, and average maturation time only 4 weeks, which is very interesting, with 10% of patients with early cannulation, meaning less than 2 weeks, which makes this intervention very interesting. So in conclusion, I would say that percutaneous arteriovenous fistula creation with the ellipsis device is feasible, very safe, efficient for giving prompt functional vascular access for hemodialysis. This is minimally invasive. This is a one-step confection. This is a very fast procedure under ultrasound. You don't need any X-rays or contrast. It's less than 20 minutes now to do this. You make a low pressure arteriovenous fistula, which is very interesting to avoid the long-term risk of complications of normal fistula because of high flow. In that case, this is a low flow, which is very interesting. This is less unsightly for the patient, and you can really get earlier maturation and cannulation as compared to a normal surgical fistula, with less complications, as I said before, such as aneurysm or Steele syndrome, which can be very interesting, and with a high rate of satisfaction for the patient, of course. You can see the kind of fistula you can get with the device as compared to some very high flow fistula with surgery. Of course, you need the specific education of nurses and nephrologists because this is the kind of fistula you have to puncture under ultrasound sometimes, and you have to pay attention that this is not too much deep to avoid this, but it can be very interesting in very selected patients as a second choice if distal radiocephalic fistula is not possible surgically. Thank you very much for attention.
Thank you, Professor Lefroy, for a very nice presentation for new technique, safety, and less invasive. We have some questions, but we will discuss in the end of this session. And now I would like to introduce, we will meet again Professor Vidal for the new topic talk about the fair Emborrhoid. Yes, please, Professor.
Hello, I'm really happy to share with you these presentations about fair Emborrhoid and the possibility of arterial embolizations with permanent and absorbable sutures. Thank you again for the invitation to your Congress. So the ultimate goal, I think, of all interventional radiology is to provide the best care to even our most vulnerable patients. And which are some symptoms and some tragedy that we can do something, where we can do something. It's clearly a car or bike accident with trauma and postpartum hemorrhage. In this case, embolizations of the pelvic is really, really helpful for people who are healthy. It's not old people with cancer, it's really people which are young. If we look at the health access and quality index, we see that this map is almost the same map that the life expectancy. And if you live in a blue country, you have a life expectancy which is really high. But of course, if you live in a country which is more red, the life expectancy can be low as 45 to 50 years. If you look at the maternal mortality, it's almost the same map. And that means that where you don't have the care, of course, you have a maternal mortality, which is really high. In France, it's around 80 per 100,000 births. In Senegal, for example, it's around 200. So is it a fatality, these things? Is it a trouble of access to formations and training? Is this a trouble of access to X-ray and ultrasounds, or it is a trouble of access to medical device? This is very interesting, because why interventional radiology is not enough developed in some emerging countries. If we look to access to formation and training, there is a lot of local strength. I'm sure in Vietnam there is a lot of strength. In other countries that we are visiting, like Senegal, for example, we are working a lot with Senegal. They are very good interventional radiologists. They have had good formation. They have done the fellowship in France or in other countries. There are also a lot of possibility to do some educational program. There is, for example, Road to High Hair, which is led by Fabian Lag-Gob in Yale, and which give a lot of formations. So of course, formations is important, but there is a lot of possibility of formations. Is it a problem to access to X-ray and ultrasound? This is a really modern interventional room, which can cost a lot, but with this device, which is X-ray and screen, you can do a lot of things. That means you can do, for example, pelvic embolizations. So you don't need cutting-edge technology to save life. In many countries, in many emerging countries, interventional cardiology can share the room with the interventional radiologist. And it's good, I think, because the basic tools like wire, catheter, sheet, introducer, all these kind of things are some things that you can use both in interventional cardiology and in interventional radiology. If there's a problem to medical device, access to medical device, then it's very interesting because in a lot of emerging countries, these devices, which are embolic devices, are not distributed by the company. The big company have no network of distribution in this country because they argue that the economic work is not enough to have this network. So usually these devices are difficult to find. And when you find them at a very high price. That means that, for example, sphere, a vial of sphere in France is around 300 euros. In Senegal, it can cost around 1,000 euros. So in an emerging country, you have the cost of a device which is 3 to 4 times the cost in France. It's completely crazy. So of course, some of the devices like gel foam can be very cheap, but some of the other devices can lead around 300, 400, 500 euros. So is it a problem? Yes, clearly it's a problem. When you have an interventional radiologist, which have the skill, when you have the X-ray, when you have the patients who bleeds, and you don't have just the things to put in the artery to block the artery and do the hemostasis, it's a big deal. So with Jafar Golzarian in Egyptia, we was thinking about doing something which is high quality and low cost. But low cost is interesting, but we don't need to be inside the circuit of the medical device because it will have the same troubles. So we was first thinking to use hydrophile cotton, because hydrophile cotton you can find everywhere and it works. We have done a lot of experiments, but it leads to adenopathy, inflammations, and it is not the best tool. So from the cotton, we go to another point of, we was thinking of thread of cotton. So was thinking of thread of sutures. You see, this is one of the first draw of vascular suture, which come from French surgeons in Lyon, in France. And every day, surgeons insert sutures in the artery. This is the sutures of aortic valve. And you see here the suture which stay in the artery. So we said, okay, we can inject directly sutures. If you look at that, this is a torpedo of gel foam, and this is a fragment thread of sutures. You see the size and you see the aspect. It seems to be clearly the same. This is completely resorbable, and this is resorbable or not resorbable, and you have different size, and it's sterile, and you have some in all the hospital on the earth. So clearly it can be a good tool. We have looked the compatibility of the size of the thread of sutures with the catheter. So you can have thread of sutures, we can go in microcatheter, but also in a whole the catheter. So it's very easy to use. So we have published the first paper in VSIR in April 2019 about the concept. And the concept, we have done experiment on PICS on acute and chronic setting. So on the protocol, we have CT scanner, angiography, histological study, and we have done embolizations of pharyngeal, mesenteric, kidney, splenic artery. We have done all these embolizations. So for example, splenic here, the catheter is here. We have put the thread of suture here and blocks here on the kidney. So we have looked about the technical success and the non-target embolization risk. On the chronic groups, we have kept the PICS for 3 months, and we have done embolizations with absorbable and non-absorbable sutures. So you can see here, day 0 M3, 3 months, we have embolized both the inferior polar or kidney on the right and on the left with absorbable suture. At 3 months, all the embolized artery with absorbable suture, we will repermeabilize. It's interesting because in the non-absorbable suture, the arterial embolic material were always there, and there is nothing in the absorbable suture. All the material has been reabsorbable. There is no inflammations, no perivascular granulocytic infiltration around that. So when we have done the first experiment, we said this can be useful, this thread, to do embolizations like coils. We said, okay, it will be a big deal to do a non-spherical particles. With non-spherical particles, you can treat benign tumor like fibroid, which is, for example, a big deal in Africa. You can treat malignant tumor to do blood embolizations. So this is the thread that we have cut with scissor. You see here the cutting, you can be cutting a little bigger or a little smaller. So we have done a study around that we have published also in VSIR. We have looked at when you ask people to cut as small as possible with scissor, they cut around 900 micron, and this is the repartitions of the sphere. So you see the repartition of the sphere, the different operator, which are not medical doctor, which are only people who do the cutting. So there is a good reproduction of that. And you see the sphere here in the syringe, here at the lab, where we are doing the experiment on PICS. So we have done embolizations of classical sphere of the market, Embozen 900, versus our first sphere, which we have done with thread of sutures. So here is the result. So you see the embolizations of upper pole of the right and left kidney with both sphere. So here you see the infarction of both kidney. And here you see in purple, it's Embozen sphere. And here in blue, it is a suture sphere. So this is Embozen, which is spheric, and this is first sphere, which are not spheric, of course, because they are cut in the biggest part. This is the length, you see, 600 by 300, which is the diameter of the thread of sutures. So you can see here Embozen, here suture sphere, and this is on the before embolizations and 3 months after embolizations. So there was no difference on the 6-pig about the perfusion defect on DSA, the cortical atrophy, the volume of the kidney. The result of embolizations was the same. We have no infiltration, no inflammations. The only point, of course, is the time of the procedure is longer with the sphere than with Embozen, because when you use a sphere, like you use a PVA, it takes more time to do the percolations of the sphere inside the catheter to avoid to have a blockage of the microcatheter. So where we are now, on the ethical committee, we know that the toxicity of this suture is very well known. It has been inserted in every country, for the endovascular implantation of suture is okay. Most important, it has been already done and already published, and especially with freed of silk sutures. So anyway, it has been already done in patients. What is the advantage or disadvantage of that? The advantage, of course, is low cost. It's available worldwide. It's very easy of use. You just cut your freed of sutures and you percolate in the catheter. We know about the long-term safety. The disadvantage is the linear shape. It's not like coils. You don't have a sphere, a form, a coils, which can clearly block at a part of the artery. But when we look at what we have done experimentally, it blocks really closely, like a torpedo, gel foam torpedo. And of course, it's not radiopaque, such as particle and gelatin. So either the clinical impact for patients, yes, of course, because exfoliations within the first 24 hours after delivery or post-traumatic abdominal pelvic hemorrhagic wounds has a very high mortality. We know that. So if you have just a needle, a wire, a 5 French catheter, and freed up sutures, you can do that. It's not a lot of device. That's why I said. So the first clinical case which has been published 2 years ago by the team of Professor Diop in Senegal. So this is a perfect example of what can be done. It's embolizations of a life-threatening bleeding. This is a false aneurysm of the kidney with a huge retroperitoneal hematoma, hemodynamic shock. So Professor Diop insert a 5 French catheter here. He can go to the place where there is the bleeding. He just insert 4 fragments of 1 centimeter of non-absorbable suture, polyamide monofilament, and he had a complete occlusion of the targeted vessel in 3 minutes with clinical recovery. Now they have done plenty of other patients with that, but this is the first case which has been published. So here again, for the material which has been used, we have only 1 needle, 1 5 French catheter, and 4 fragments of sutures, and the bleeding is treated. So clearly, I think so. So this is our consortium. This is the team we have working with in Cambodia. This is Senegal. Here are the country we are involved right now with Ferrambo. There are plenty of patients working. For example, Gisoules, which is from the University of Montreal, for job from Senegal. Gloria Salazar, which is really helpful from Harvard, which works with us on development. And very interesting, the paper that Yaswa Kiare has written about interventional radiology for womb. Of course, Ferrambo is one of the key to save life in emerging country. And I think the conclusion of the paper say our high interventional radiology should not be just for the wealthy. We should look to cheaper high hair to make high hair loved by everyone on the planet. And clearly, I think we can reach this goal. So one of our medical doctor is actually in PhD working on that. And it's really important because we are working on sphere and we want to have a sphere which are more regular to do fibroid embolizations, for example. And this is the beginning of, we are working with engineer school, which are working on a device which is going to cut the thread at the regular size, 500, 600, or 700. So this tool will be less than 500 euro, and we can give this tool to a medical center, for example, in Dakar. So the day before the intervention, of course, it's not for emergency, it's for malignant tumor, benign tumor. You can cut the thread, you put the thread in a small bag, you put it at the sterilizations in autoclave, and the day after you can use the sphere as normally with other sphere. So what we can say today for fair embo and embolizations with absorbable suture and non-absorbable suture is feasible, it is safe, and it is effective. So I think clearly we have here an inexpensive and widely available embolization agent in hospital worldwide. Again, we have spoken with a lot of economic partner, especially in emerging countries. It's really important to know that interventional radiology for this kind of procedure are cheaper than surgery and other things. It's cheaper to do an embolization of the uterus for postpartum hemorrhage than doing an hysterectomy. If you do an hysterectomy, you will have a follow-up stay at the hospital, which will be around 10 days, and the patients will have no more uterus, and doing the embolizations is really quicker, cheaper, safer. So I'm quite sure that we can go really further with embolizations in emerging countries, and I am really happy to participate, and I will be very happy to come to Vietnam if necessary and if I can help. So thank you for the